Okay, so we're going to start off with some of the classic transforaminal approaches. Can you wag this way a little bit more? Yeah, just take a shot there. Okay, good. So this is sort of the wag that we want. Okay, let's go back to AP. So I'm going to start off with the extraforaminal, and it's great to be back here again. Last year I had a severely scoliotic cadaver, so thank you for not giving me one of those.
You were a champ, though. You were a champ.
So extraforaminal is to me a very different approach, and as Dr. Chol Kim said yesterday, and Dr. Hofstetter said today, it's a completely different beast and animal. So I think about it a little bit different than I do for other transforaminal approaches. You know, the obvious thing is the disc is more lateral. So your approach trajectory is going to be starting more medial, and therefore you're going to be a little bit more steeper. So the first thing we'll do is we'll set this up. As usual, you want a perfect AP X-ray, and you want a perfect crisp end plate of the level below. So for our demo, we're going to tackle the L3-4 level. So I've got the 4 end plate there. And so let's take a shot there. And I typically, one more shot there. Okay, and so I've already marked this line out, and so typically I mark the end plate and then a midline mark shot there, okay, and then I'll mark a trajectory, so shot there, one more shot there, and let's go one more right there. Okay, and so what I'm trying to do is I'm basically trying to hug the top of the ipsilateral pedicle. We're approaching on the right side, and then I will pass a trajectory through the contralateral pedicle. For an extraforaminal disc, it really doesn't matter how steep or shallow your approach trajectory is. So I'm going to mark off this line. I think for these, usually you can tell how far off the midline you need to be based on the preoperative MRI. But for this demo, obviously, we don't have an MRI to look at. So what we'll do is we'll come to the lateral. So 5, 4, 3, 4. Okay. So do you want to slide to the foot just a hair? That's good. That's good. Okay. And so one way you can kind of measure, so if you want to take roughly a 45-degree angle to the foramen, you can draw a line such as this shot there. Okay. And one more shot there. Oh, one more shot there. And one more right there. Okay, and so what you want to do is kind of put the tip of the marker at the front of the disc space. Shot there? Okay, and so wherever this hits the skin is roughly the distance you're going to be off the midline if you're going to take a full transforaminal approach. So I've kind of marked that right here. That's about right here. L3-4, do we also have a ruler? And at L3-4, if you're doing an extraforaminal, typically that's going to land us around 6 centimeters off the midline. So if you take the traditional, we're about 9. So we'll kind of move that mark a little bit medial just to account for that. So I'll just kind of start, let's say, 6 to 7 off the midline. And then can we flip the C-arm orientation to my view? Do you understand what I'm saying? So just flip it horizontal and then lay it down 90.
And Meng,
Yeah, and then turn it clockwise 90. Great. And then do we have the targeting needle?
Meng, the actual real world situation, do you actually do this, or you just use MRIs?
I just use MRIs. Yeah. So I think for an extraforaminal, you should just use the MRI and target based off of that. So we picked out this starting point. So I'm going to take one more shot shot there, and let's just see where we're at. It's okay. We can leave it here. Actually, can you drop the C-arm a little bit? Okay, or raise the table. Yeah, that's great. Okay, so we can sort of see the tip of the needle, and that's a good starting point. And I actually like to target on the lateral because what I like to do is actually just miss shallow first. And so we'll kind of get this started here. Let's see a shot there. All right. And so we're going to go until I hit bone there, shot there. So I've hit bone there, so I know I'm very, very shallow. That's if we were to get an AP, we're probably on the spinous process. So I'm going to then steepen my hand at this point, shot there. Okay, so I'm on the facet joint. I'm going to, again, micro movements, shot there. Small movements make a big difference here, right? And then shot there. Okay, so let's go back to AP. So I felt the facet, and then I basically just followed and walked my needle off into the foramen. Okay, so that's a good looking picture. If I advance a little bit more, shot there. And then can we bring this back up to an upright view with a left-right flip? Yeah. There we go. Okay, so this is exactly where you want to land. I'm hitting bone, and we can see that corresponds with the back of the vertebral body, and I'm still lateral to the medial border of the pedicle, which is where your lateral recess is. So at this point, I'm going to commit to this, and do we have the knife? And so I'll make an incision over the needle. And then at this point, we can switch out the guide wire. Let's just go one step. Let's see another shot there. Okay. So for the extraforaminal approach, you obviously don't really need to remove any bone. And so what I typically do is I don't ream for these types of cases. You also, generally speaking, I wouldn't ream anyway just because of the pathology. Extraforaminal discs are going to be pushing your dorsal root ganglion dorsal towards you. Okay, so this is a one-step dilator shot there. Okay, and so at this point, I would just go ahead and bring in the working channel. You can see that these are beveled, and this bevel, the curve on the tip of it, is what you're going to use to retract the exiting nerve root. Okay, and so once we get in, shot there. Okay, and then let's get a lateral just to demonstrate where we are.
Meng, do you have any superstitions about which way you drop the cannula to avoid?
I mean, I was taught by Christoph that you always have the open side facing the nerve so that you can glide over the nerve. So that's just what I do. I'm not sure if ultimately that makes a difference or not. What about you guys? You know, that's great. You can come back
I
around.
do the same.
So you can see that we're in the right position for an extraforaminal disc. Can we lower the height of the bed now? Keep going. Keep going. Keep going. All right, that's great. Okay, thank you. Okay, so once we are ready, we can get our scope in. We're going to adjust our focus here. And so at this point, the first thing you want to do is just identify the bony landmarks and the bony structures, right? Oftentimes you'll get some foraminal bleeding that you'll have to take care of, but you can see caudal is to the left of the picture right now, cranial is to the right, and then obviously dorsal is around 12 o'clock. So you can see the periforaminal ligaments covering the bone here, and then you see the foraminal fat right here. So if we were to take a shot right here, this would be on the pedicle. Take a shot there of L4. Okay, you can see that. And then if you come around, you can actually get into the spinal canal shot there. So that should be confirmation of our lateral recess. Okay, that's great. And obviously the other surgeons are going to demonstrate the rest of this, but this is essentially it. Once you get to this point, what I typically do is then I'll turn the camera cephalad to look for the exiting nerve root. You'll see a lot of foraminal fat. You'll see these ligaments, and you can take these down using a Kerrison rongeur. I oftentimes just sit here and use an RF probe to clear it out and use this as a dissector to mobilize. Do we have a Kerrison? Thank you. Oh, I think this is too big. So once you find the nerve root, what you're going to do is you will leverage that cannula to retract it and find the disc underneath it. So let's see this.
So Meng, do you routinely always look for the exiting nerve root, or because
Absolutely. I think you absolutely have to look for it. Early on, I had some failures because I don't think I don't think I truly saw the nerve root. So I always look for the nerve root. You'd be surprised sometimes you'll find the herniation really cephalad. And so unless you're seeing the nerve root, I don't think you can be confident that you've truly gotten the decompression. I don't know how you guys feel, but I always look for the nerve root.
I completely agree with you, Meng. In some situations, the patient has, lateral recess stenosis as well. So I often will do kind of a hybrid approach where I will decompress lateral recess and then use the traversing nerve root to find the axilla and the exiting nerve root and confirm that disc herniation is
Let's see the RF probe.
the exiting nerve root.
Yeah, I think this could be it.
That's beautiful.
So I think
yeah,
this
the nerve right there.
Yep.
Can you kind of highlight the nerve for everyone and how?
Yeah. Let me just
hard
get
for
this,
some
clean
people
this off a little
to
bit
see the
better.
edge right there.
You can see it now much more clearly. So here's those radicular arteries,
Looks like you're
and sometimes they can cause quite a bit of trouble with bleeding. So, you can actually use if you get one of those arteries and it starts pumping, and you get a red screen, what you can do is actually you can sort of in neurosurgery we have cottonoids, and so you can use this as sort of a cottonoid to block it off, and then slowly look at the vessel and RF probe it. But that's the exiting nerve root right there, and you can see if I pulsate. Sometimes you can kind of see it move. You obviously see it move in a real patient. And so once you find the exiting nerve root, then you can get the cannula. You see I'm doing a lot of this rotational maneuver. So I'm going to get my bevel underneath the nerve root. Then I can really retract it out of the way if I need to. And you can go pretty far here. Let me see the RF probe, and let's come in with the AP. And we'll wrap up here and hand it over to Peter.
Meng, it also looks like you identified the medial branch.
I'm sorry, what did you say, Christoph? I couldn't hear you.
It's my thick Austrian accent. It looks like you also identified the medial branch when you were rotating the nerve, which is an important landmark that you can cut the medial branch if you'd like.
Yes. So let's take a shot right there. So you can see how far you can see up there, and we know this is definitively the exiting root just based on the position of the cannula. One more shot there, and the relationship to the pedicle too, right? And so if you're getting a disc herniation, extraforaminal herniation, it should be right here, and you can rotate we rotate that root out of the way, and then you can do all of your work, and it's right here. So let's take one more shot right there. And you can see that we're positioned exactly where an extraforaminal would be.
So that was an important point. You showed the hidden zone of McNabb, which I think a lot of people miss herniations in there. But I think that we have to move forward a little bit in the interest of time. So maybe we can go on to Peter right now.
Yeah. All right. Thank you.